Hello guys, I am Dr. Ravindra Savarkar and I welcome you back to Med School. Topic for this video is WPW syndrome and other pre-excitation syndromes. So what is pre-excitation syndrome? Pre-excitation syndrome represents group of disorder where there is congenital presence of accessory pathway or bypass tract between atria and ventricles bypassing AV node. Impulse passing through bypass tract causes early activation, that is pre-excitation of part of or complete ventricle. Most common type of bypass tract is bundle of Kent, present in Wolff-Parkinson-White syndrome. In WPW syndrome, atrial activation occurs normally, hence P wave is normal. Impulse is further conducted by both normal as well as accessory pathway. Conduction through accessory pathway is fast as compared to normal conduction pathway due to AV nodal delay. As impulse bypasses AV node and AV nodal delay, PR interval will be short on ECG. When impulse reaches ventricle through accessory pathway, it starts activating adjacent area of ventricles. This activation being done by abnormal pathway is slow and little bizarre. Hence, deflection form on ECG is slurred. This is nothing but the delta wave of WPW syndrome. By the time this pre-excitation occurs in small ventricular area, impulse reaches bundle branches and activates remaining ventricular area. Hence, rest of QRS complex is normal. So, in WPW syndrome, PR interval is short, less than 120 millisecond. Early part of QRS complex is slurred, also known as delta wave. QRS complex duration is more than 120 milliseconds, mainly due to initial slurred part. ST segment and T waves are usually normal, but there can be ST depression and T wave inversion due to repolarization abnormality associated with pre-excitation. In this ECG, PR interval is only 80 milliseconds. Delta wave can be seen clearly. QRS duration is more than 120 milliseconds. Hence, this ECG represents WPW syndrome. This is also an ECG of WPW syndrome. There are ST depression and T wave inversion in lead V1 to V4. These changes may represent repolarization abnormality, provided they are not of recent onset and patient is asymptomatic. So, what are the complications in WPW syndrome? These patients are prone to develop re-entry involving bypass tract and normal AV conduction pathway, causing AVRT. These patients are also prone to develop atrial fibrillation. Let's understand how re-entry circuit forms. There is a closed circuit formed by part of normal conduction pathway and accessory pathway. Owing to different conduction speed and refractory period of both the pathways, this circuit is vulnerable to form re-entry. Normally, sinus impulse is conducted through both the pathways. But sometime when sinus impulse reaches distal end of internodal bundles, one of the pathway amongst accessory pathway or normal conduction pathway remains in refractory period. Commonly, accessory pathway is the one in refractory phase. So, impulse is conducted through AV node only. By the time impulse reaches distal end of accessory pathway, it is out of refractory phase. Hence, along with conduction into ventricles through normal conduction pathway, impulse is also conducted retrogradely into atria via accessory pathway. By this time, atrial conduction pathway is out of refractory phase. Hence, not only atria are activated by this retrograde impulse, but it is also conducted antigradely via AV node. Impulse from AV node is again conducted in normal conduction pathway as well as in accessory pathway. In such way, impulse keep re-entering into the circuit, activating atria and ventricle, resulting in atrio-ventricular re-entrant tachycardia. When antegrade conduction occurs through normal conduction pathway and retrograde conduction occurs through accessory pathway, it is called as orthodromic AVRT. When antegrade conduction occurs through accessory pathway and retrograde conduction occurs through normal conduction pathway, it is called as antidromic AVRT. Orthodromic AVRT is a narrow complex tachycardia with rate ranging from 150 to 250 beats per minute. It is sudden in onset and termination. Baseline ECG may show sign of pre-excitation like delta wave in WPW syndrome. There are absent P waves. There are no pseudo S or R' wave. There is marked ST depression in multiple leads. When P wave is visible, RP interval is shorter than PR interval. But unlike AVNRT, RP interval is more than 70 milliseconds. Rhythm in orthodromic AVRT looks like this. In this ECG, RR interval is 8 small boxes long and constant. Hence, rhythm is regular and heart rate is 1500 divided by 8, that is 188 beats per minute. There is ST depression in multiple leads. P waves are not distinctly visible except in lead V4. If look closely, RP interval is shorter than PR interval. RP interval is definitely more than 2 small boxes long. This means RP interval is more than 70 milliseconds. All these features are suggestive of orthodromic AVRT. Antidromic AVRT presents as wide complex tachycardia on ECG. That's why antidromic AVRT is often confused with ventricular tachycardia. Brugada's criteria is designed to solve this problem. Points in Brugada's criteria are absence of RS or equiphasic QRS in precordial leads, RS interval duration more than 100 milliseconds in any precordial lead. RS interval is interval between start of R wave to nadir or deepest point of S wave. Presence of QR or QS morphology in lead V6. Presence of ventriculo-atrial dissociation in any of 12 ECG leads. There are some clinical features which support diagnosis of VT against AVRT. They are age more than 35 years, long QT interval in baseline ECG, presence of congestive cardiac failure, history of ischemic heart disease, history of cardiomyopathy, history of structural heart disease, and history of sudden death in family. There are wide QRS complexes in this ECG. RR interval is constant and 12 small boxes long. So, heart rate is 1500 divided by 12, that is 125 beats per minute. There is no capture or fusion beat. So, let's apply Brugada's criteria to see whether it is ventricular tachycardia or not. There is RS or equiphasic QRS in lead V4. RS interval in precordial lead is less than 2 small boxes, so it is less than 100 milliseconds. There is no QR or QS pattern in lead V6. Inverted P waves are present in lead V4, but there is constant relation between P waves and QRS complexes. Hence, there is no AV dissociation. So, these ECG features are consistent with antidromic AVRT rather than ventricular tachycardia. In atrial fibrillation associated with WPW syndrome, conduction of impulse into ventricles can occur through bypass tract only, AV node only, or both bypass tract and AV node. When conduction occurs through bypass tract only, it has two important effects. Ventricular rate will be higher, usually more than 180 beats per minute and sometime up to 300 beats per minute, as a refractory period of bypass tract is lesser than AV node, making conduction of impulse faster. Ventricles will be activated through abnormal pathway only, hence QRS complexes will be wide and bizarre. For workup of WPW syndrome or any pre-excitation syndrome, diagnosis is made with ECG, and electrophysiological study is required to locate the accessory pathway. In treatment, ablation therapy is curative. Thank you for watching this video till the end. If you have any query or suggestion, please write it down in comment section. If you like my work, please like this video and share it with your friends. To get notified about next video upload, please subscribe to the channel and hit the bell icon. Till next video, take care and keep learning.